Hello everybody, it's truly an honor and pleasure to be part of this fantastic conference. I want to thank the program director for inviting me and inviting Robert Wood Johnson. I've been asked to talk about innovation in EUS guided drainage technique, and we're going to just immediately jump into this discussion by talking about one of the most innovative and most frequently used drainage after fluid collection, which is EUS guided gallbladder drainage. As you know, surgical cholecystectomy is a gold standard for management of cholecystitis. However, patients that are not surgical candidates due to comorbidity or end-stage terminal oncologic diseases, they probably should be receiving a more minimally invasive intervention. The complication rate of percutaneous drainage is around 12%. There's a lot of morbidity associated to those external drain. Hence, EUS guided gallbladder is a very interesting alternative for those options, for those patients. A meta-analysis from 2016 showed that actually we have 93% technical success and 97% clinical success of when we use EUS guided gallbladder drainage with 13% adverse events. This is an interesting study that we've published a few years ago now in 2018. We had 155 patients with 7 centers. Most of the centers at the time were not using the lumina-posing metal stent, so they were using either plastic stent or biliary covered stent to drain those patients. There was no difference in terms of technical success, no difference of clinical success when we compare to percutaneous drainage, no difference in adverse event, and very interestingly, there were fewer repeat intervention in the EUS gallbladder group. So recently, Anthony Theo group published a very nice randomized controlled trial comparing head-to-head EUS guided gallbladder drainage to percutaneous gallbladder drainage, showing that EUS guided gallbladder drainage is superior on multiple outcome measures, whether it's the technical success, the mortality, and of course, unplanned admission. And that is a very interesting concept where finally now we have in a randomized controlled trial the proof that this technique works very nicely. So I'm going to show you here a quick video about EUS guided gallbladder drainage using a lumina-posing metal stent. We're using here the cautery enhanced version. So you can see here in one-step procedure, we can access the gallbladder with the cautery enhanced device, deploy the first flange, bring that first flange a little bit against the wall of the stomach in this case. So like this, we are opposing the gallbladder wall to the wall of the stomach, and then once the apposition is performed, we can then deploy the second flange into the stomach, and you can see how safely here we created an anastomosis between the stomach and the gallbladder, and in this case the patient is palliated. So you can see that in some cases you have very nice access to the obstructing stone, and you can eventually get rid of them. The biggest question that people come back and ask us, and this small series try to respond to this, is what do we do with those patients that may eventually later on go to surgery? For instance, patients that are having decompensated heart disease. What do we do with them? Can we offer them an EUS guided gallbladder drainage, and then once they're stable, get a cholecystectomy? And so in this study where we compare contemporary patients in both groups, treated percutaneously or by EUS guidance, and then subsequently went on and had surgery, there was no difference between the rate of open versus laparoscopic cholecystectomy, and no difference in the term of post-surgical adverse event. The next drainage procedure, obviously, is the EUS guided gastrojejunostomy. So within the last few years, really treating gastric ulnar obstruction with EUS guided GJ has really become a very interesting concept, which has been used over and over again. The exact term actually is an EUS guided gastroenterostomy, because sometimes the anastomosis is not with the jejunum, but with the distal duodenum. So you can see here the first 3 large study came from Japan, from Hopkins and our own institution. And all those initial studies were really showing feasibility data. Later on, more study with larger patients, including patients that were done overseas, demonstrated actually that indeed this technique seemed to be very efficient and safe. The next step was actually to compare this kind of procedure of EUS guided GJ with laparoscopic GJ, and you can see those two series came up with the same concept and the same result, with the technical success being similar, with obviously a lower procedure cost and better safety model. Now, how does it compare to antral stenting? It definitely has an equal efficacy and safety, but the beauty about using EUS guided GJ is you have less gastric outlet obstruction recurrence and less reintervention. Now, what is the learning curve? This is a study we did and recently got published in JCG. You can see the median procedure time in our study was 88 minutes, and in somebody trained in therapeutic EUS, it takes 7 procedures to achieve efficiency. And this is a difference between getting efficient and becoming an expert. Clearly, having skills in therapeutic EUS is crucial before embarking into those kind of procedure. Now, there's a lot of way to do this procedure. It can be done using a direct technique where you puncture directly with the hot axios. It can be used as a two-point technique where you first inflate the bowel with a needle and inject a normal saline mixed with methylene blue. You can also use balloon-assisted gastroenterostomy, or a reverse GJ where you actually cross the obstruction and then you connect the small intestine with the stomach. And a very nice study here published by our colleague in Hopkins, where you can see that they compare those two techniques, and the direct puncture was actually the winner when you compare with the two-step procedure where you're using a balloon. So this is our technique that we have named the Milan Technique. We have used the same technique used by the Milan Technique of Paolo. And you can see the very first step is to access the small bowel through the obstruction. We are going to advance a guide wire as deep as we can into the bowel. Here we're using a ball tip preloaded with a Hada jag. After removing the ball tip, we're going to advance a 7 French nasocystic drain. This will be used to fill the small intestine with a mixture of normal saline and methylene blue. So once the nasocystic drain is placed into the small intestine, the upper scope is removed, the echoendoscope in there advance, and you can see by EUS we're going to localize a distented loop of bowel, puncture this loop of bowel with a 19 gauge needle, inject contrast, confirm that we are indeed into the small bowel, and then once we have confirmed using hot axios in a direct puncture technique, we're going to access the small bowel. The first flange is then deployed into the small bowel, and the second flange will be then deployed into the stomach. We like to place a guide wire as a backup in case there is migration or a dislodgement of the stent, so we try then to keep access into the small intestine. You can see here that once the lumina posimetal stent is opened, we're gonna place a balloon and deploy fully the lumina posimetal stent. So the next technique, which is inspired from the GJ, is a technique that we customize in 2014, is EUS directed transgastric Ercp, a procedure we use for people that have a Roux-en-Y gastric bypass. This was performed in the first human being in 2014 when I was still at Cornell. We created this procedure and we literally use step-by-step technique that allow us to do it safely. Simply because in those patients that have a gastric bypass, every other technique to perform ERCP is either extremely challenging, such as deep enteroscopy, which is only successful in less than 60% of the time, or is extremely laborious and complicated using two different teams, the laparoscopy assisted ERCP, where you have to go to the operation room and work with your surgeon, where you place a trocar into the excluded stomach to allow you to do an ERCP. Percutaneous drainage, unfortunately, doesn't offer a permanent solution. It only offers you a decompression, and you're still dealing with the morbidity associated with a third drain. So this is one of the first large studies that we published a few years ago now, where EDGE has allowed us not only to do ERCP but also EUS into the excluded stomach, and you can see how safe and efficient this procedure is. Initially the procedure was criticized, and then every single team that criticized us start publishing their own data and have now officially adopted this technique for their patients that have a Roux-en-Y gastric bypass. Now, a large study was recently published with 166 patients, 12 centers were involved. The technical success was 98%. There was 17% of adverse event, only 2.4% were severe, 12% only of persistent fistula, 70% required to be closed endoscopically. This was significantly associated with patients that have diabetes mellitus and well known to have more difficult cicatrization. Now, we did a cost-effective analysis here comparing EDGE to laparoscopic ERCP. EDGE has the same technical success, less adverse events, and it's obviously a shorter procedure and cheaper procedure compared to the laparoscopic assisted ERCP. Now, obviously, the same thing can be studied when we compare EDGE to enteroscopy assisted ERCP. You can see here that EDGE has a higher technical success, shorter procedure, and most important, shorter hospital stay, which is very important for those patients. Very nice cost-effective analysis that was done by Todd Barron comparing EDGE, enteroscopy assisted ERCP, and laparoscopy assisted ERCP, and one more time EDGE was the winner when we compared the three techniques together. This is a very interesting case that we published a few years ago, where actually we used EDGE as a technique to drain a pancreatic fluid collection that was in the vicinity of the excluded stomach. So you see, first step is to locate the excluded stomach that has this spider appearance. Then we're gonna inflate this excluded stomach by a mixture of normal saline. In this case here, we're using the luminapose metal stents over the wire. You can do it freely also when you have such a nice target. We're gonna deploy the first flange, oppose the excluded stomach to the pouch. Once the apposition is performed, we're gonna deploy the second flange of the luminapose metal stents. And here we are now. We finally have access to the excluded stomach. We can then dilate the luminapose metal stents and then get access into the excluded stomach, perform the next procedure, which can be an ERCP or can be an EUS. In this case, we're going to access the excluded stomach, but for the specific indication, in this case, to actually drain a fluid collection. As you can see here, you can perform an ERCP as well, and you can see how nicely the ampulla look like, and this becomes really a typical procedure where we basically are able to perform whatever procedure we need. Therapeutic EUS for drainage is an exciting and rapidly expanding field. There is a new application for creativity that are emerging every day. Already minimally invasive endoscopy therapy are gaining support over more invasive surgical and percutaneous alternative. We expect that safety and efficacy of all those interventions will continue to improve as operator experience and endoscopic equipment continue to develop. Thank you for your attention. If you have any question, please don't hesitate to send me an email at the end of this conference. Thank you all for spending time listening to our talk. We will see you soon during the live section.